Welcome to the Executive Innovation Show podcast, where we bring you real executive conversations with industry game changers and thought leaders. We ask the questions you're thinking, what you're scared to ask, and we make your brain hurt afterward. With your host, Carrie Jitsi Wells, co-founder and CEO of One Touch Video Chat, live video interviews, and the nonprofit Humans Helping Humans.
Hello, everybody, and welcome to today's podcast of the Executive Innovation Show brought to you by One Touch Telehealth. Today is our 75th episode special. We're going to be highlighting the best healthcare podcast of 2019. We've got some awesome guests and show for you today. We're going to be talking about big changes we've seen in healthcare this year, just in our January to December shows. Huge increases we've seen in digital healthcare technology such as telehealth, remote patient monitoring, and some innovative guests and physicians we've had over the last 12 months. We're going to be talking in a couple of different segments today. First, we're going to go through eye-opening stats that still have us talking about those shows throughout the year. We're going to be talking about innovative ways healthcare is changing and some big changes we've seen in payer models for telehealth over the year. And this year is the year of telehealth adoption. So really going to be highlighting some innovative ways and innovative companies and physicians, hospitals that we've had over the year.
Yeah, great. So to start off, we'll start with the eye-opening stats that we still talk about today. We'll start with these 4 clips. Carrie, if you can you just tell us why you picked these 4?
Yeah, so the 4 clips that we picked, the first one is really around youth suicide and mental health. The second one is veteran suicide. Third is the foster care system and just some eye-opening stats about that and how we can really change. And the last one we talked about a lot this year was really about the aging baby boomer population and just a lot of the shortages and things that we hadn't even seen yet that are there to come. So let's start.
Yeah, so first we'll listen to Clinton Fopel's episode from January 10th entitled Spreading Youth Suicide Prevention, One School at a Time.
We learned pretty quickly through our polling technology that, that nearly a third of the students, in fact, just under a third of the students, struggled in the last 12 months with suicidal ideation. And so that means of 80,000 students that we polled, 30% have seriously considered suicide in the last year.
It's heartbreaking.
And although it's heartbreaking, yes, it's as a parent, you cringe and you get sick to your stomach about it. But what happens, Carrie, in these situations is that we actually see that there's power now in those kids that said, yes, they struggle. And so what we're seeing on average is that 5% of the student population is willing to take the immediate next step, which is to talk to a trained therapist at the school that day that we bring in. We usually bring in about 20 people. And so immediate care is provided. It's not therapy. It's not counseling. It's just a consult to be able to say, tell us more about your story. Tell us more about where you're at with your struggle. Then we see 18% of that student body chat into our chat center to see, is this real? Are you guys bots? Are you real human beings? And some of them do get deep into their struggle right away because they have been waiting, they've been begging, they've been praying for someone to ask them how they're really doing and to be able to get that off their chest in a safe way. So we're learning again about a third, just under a third of the students are struggling at that deep issue. The other part that's alarming is that we're seeing that 2/3, 65% of those same 80,000 kids know somebody within their circle of influence, could be a friend, could be a family member, could be someone they play sports with, that has shared with them a struggle with thoughts of suicide. And so that's, again, staggering. 2/3 of 80,000 kids struggle with thinking about it or knowing somebody that struggles with thinking about it.
So the real thing that those stats have stayed with me all year, because the second leading cause for youth is suicide. With the negativity on social media has created a lot of deferred isolation with our youth. And really, schools thinks that parents are having this conversation and the parents think schools are having this conversation. And so we really need to be looking at more ways to reach youth and video peer-to-peer counseling hotlines Gen Zs interact completely different than millennials. They're video first calling demographic. And I think we're going to see more and more solutions that are targeted for youth mental health.
Great. And then this next clip from January 24th, we have There's No D in PTSD, Warrior Suicide Prevention with Philip Folsom.
So in our most recent experience of war since 9/11, we've lost under 8,000 troops to combat. And we've done a really good job actually at saving the lives of combat troops. Our medical technology and response is never been better. So that number is remarkably low for how many battlefronts we have been in and are currently in. The scary number is that compare and contrast the 8,000 deaths to combat since 9/11 to the 150,000 suicide deaths since 9/11. It is catastrophic. It is epidemic. We are losing well over the regular publicized 22 a day number, because that's just classic suicides of I left a note and put a gun in my mouth.
So we all hear about veteran suicide and veteran mental health. I think the real shocking thing is the difference of 8,000 lost in combat versus 150,000 in suicide. And that doesn't even take into account the huge opioid that we're seeing with veterans, and the real need for veterans want to help veterans, and really enabling tools that with the mental health shortages that we have in America and rural demographics, we really need to start looking at video peer-to-peer support for veterans to be able to help veterans with certified peer specialists. I think the best is yet to come with that, and we all need to be thinking about the impact in that area.
Great. So yeah, the next clip that we're going to take a listen to is Children Without Parent Care, Foster Care and Orphans with Caroline Boudreau from February 14th.
And what we learned is that 67% of foster families quit within the first year. Most children, the average placement of most children in foster care families is 4. They go through 4 families, family after family after family after family. And every time they move, they academically lose 4 months of school.
Jeez.
They don't physically lose 4 months of school, but they academically lose 4 months of school.
So this actually, if you listen back to this podcast, this is the first podcast ever that Daniel on our nonprofit Humans Helping Humans is co-hosting that day. And within the first, I think, 5 minutes, we were both in tears with Caroline. So it was definitely a very memorable podcast for us. But I think if we look at the foster care system, if you listen to this podcast in full, the opioid crisis is driving significant numbers in the foster care system due to parents' addiction. And with the guidelines of foster families and being able to take kids to appointments and all the things that's required is creating a lot of this turnover. And so with digital technology and some telehealth and things like that, we really see a huge impact that we're able to make. And just since this podcast in February, we're already working with a lot in the foster care to really help out. So it's been an amazing year for foster care and impact, and really some innovative organizations that are changing the way foster care.
Our next eye-opening stat clip is from the show entitled Tech Innovation to Support Baby Boomers Aging at Home with Adam Savoie from April 22nd.
If you look at the aging population, the baby boomers, there are 50 million seniors in this country today, going towards 100 million by the year 2060. And we have about 3 to 4 million beds at senior facilities nationwide.
It's crazy.
So whether they want to or not, 47 seniors are going to have to figure out how to figure out care models of care that are able to enable that. Otherwise, it's going to really tax our healthcare system. It's going to create a huge overload on our hospitals.
So you've probably seen in the news all over just the number of baby boomers aging and the ratios with number of children being born versus the boomers. This is creating just a huge taxing on the healthcare system. And really, we've done a lot of shows this year on population health, on boomers wanting to age at home, caregivers, social determinants. And even since that podcast was recorded, numbers have come out, and we've got a podcast actually coming out in early January that we have 115 million seniors today, 132 million by 2030. Only, as Adam said, 3 to 4 million beds, and not huge numbers of increase, but the number of beds are highly dependent and very costly. So I think we're going to see big changes in home health and hospice and virtual care. And the other thing that I would say is don't count seniors out of technology. There's been a lot of studies. We've gone through them on the podcast this year on how baby boomers do use technology. And so I think the best is yet to come, and we're going to see a lot of changes in healthcare in regards to chronic care and seniors aging at home.
Great. So our next section, innovative ways healthcare is changing. We also have 4 clips in this section as well. Carrie, can you just tell us why you picked these 4?
So I think there's a few. The reason we picked these clips is there's going to be a big shift, I think, in some of these areas and some of the guests. The first one, we're going to be talking about patient scheduling and patients really wanting to be able to schedule their own appointments online and through mobile without having to call kind of old school and check appointments. The second one is really around telepharmacy. Going to see some big changes in the industry, both on the retail side of pharmacy as well as the consultant pharmacist side. And so we talk about that. The next one is really about full risk primary care, full risk Medicare. Seeing a lot of practice groups really going this way and bringing kind of everything in-house, really getting invested in the care and both on the financial side and the outcome side. And so we're going to be talking about that. And the last one is really this new model that we're seeing a lot of medical devices that are really direct to consumer. So historically selling through providers, selling through hospitals, things like that. Now your medical device companies are going direct to consumer, and that's created a lot of change and innovation, both on the operational and technology side of that side of the business.
All right, great. And so our first clip comes from Emily Tyson of RedX Health from October 22nd. This episode was entitled Patient Demands for Convenience, Scheduling, and Telehealth.
No, I think that's right. I mean, our goal, to your point, is a ton of operational complexity behind the scenes, and we want to make sure we're serving that and doing that justice. But for the patient and the provider, it actually should be seamless and easy. When we think about online scheduling and booking an appointment, for a patient, it shouldn't actually be much harder than making a restaurant reservation or anything else out there. And getting that consumer experience side of it's really important. And the key is you can't ignore the operational complexity behind the scenes, but how do you hide it? And so things like, to your point, you get the notice, and if it's telehealth, it's easy. You've got 2 clicks and you're in. And if not, having options appear on, do you want to add it to your calendar? Do you want to book transportation now? And really thinking about it more holistically from the consumer side. But I think you broke it down really well.
So as we look at other industries, the fact of calling and having to make an appointment is kind of a thing of a past. Really, when you look at the ability for patients to see availability in real time, cross physical locations, as well as telehealth, the days of waiting 6 weeks to get an appointment, 4 days of getting an appointment are over. And practices, hospitals, retail clinics, everybody needs to be thinking about a patient-facing scheduling on their website, as well as using waitlisting for telehealth. It's not easy with traffic and congestion and calendars to say, we had an opening at 2:00 this afternoon, when it could literally take you an hour and a half in traffic to get there. But if you could do a telehealth appointment from your home or office, you could be on wait lists. So as we look at affecting no-show rates and things of that nature, I really think we're just on the cusp of what we're going to see in 2020 for reducing no-show rates, patient scheduling, and waitlisting with telehealth.
So in this next clip, Chad Wars talks improving health outcomes through consultant pharmacists. On the August 13th podcast, he was joined by Ashley Clevens Hayes of RX Ashley.
What I think pharmacists need to be thinking about is how do we use telehealth and telepharmacy applications to engage patients. We're all worried about, Amazon entering the pharmacy space and what that means. They're going to drone prescriptions to your front porch, but there's a component of that is still the pharmacist, whether it's a consultant pharmacist or a traditional pharmacist, where you've got to have that engagement with the patient. And what does that look like? And pharmacy is unique in the sense that we don't generally physically assess patients. We take data and information and we look at med lists, and that's all something that's easily translatable over video, over chat, in a digital format. Right. So we really need to be looking at that. And I think, I could go 1,000 different directions with how pharmacy is going to be changed by this kind of technology. But I don't think we're very far away from, instead of the corner drugstore being sort of that romantic, antiquated model that everybody loved from the 50s and 60s, where they could walk down and talk to their pharmacist and do that old school thing. I don't think it's far off where a pharmacist might come to your house, at least initially, talk to you about your medications, arrange the drone drop from Amazon or whoever, and then periodically check in over your smartphone or over your computer at your house, and have that face-to-face communication while at the same time coordinating your medication. So a pharmacist might become their own sort of pharmacy minus the bricks and mortar in the future.
So Chad's with the American Society of Consultant Pharmacists, and I think both on the retail side as well as the consultant pharmacist side, everybody's been worried about Amazon getting into the prescription space, and there's a lot of others, but we're seeing a ton of pill packs. We're seeing a ton of increase in delivery on pharmacy. And what it's really, pharmacists have a great opportunity to, through video telepharmacy and other digital tools like remote patient monitoring and adherence and things like that, really expand beyond the physical walls and the physical walls of a retail pharmacy or the physical walls of a facility where they're consulting with patients. But there's a key role here with shortage on the provider side that pharmacists can really extend services and do move from transaction of filling scripts to a wellness model, which is what the pharmacists want, but the technology is now there and available to allow them to really do better in patient outcomes and get reimbursed for it.
Great. So our next healthcare innovator we want to showcase from this year's healthcare podcast is Dr. Gordon Chin. Dr. Chin was a guest on the July 30th show. Best practices in full risk primary care practice models.
Being in a full risk model, we have to have operational efficiencies so that the clinic flow is smooth and patients aren't waiting for a long time. But then we also have to build in some flexibility because we need to be there when the patients do need us. I think in terms of telehealth and the opportunity for video remote visits, I think that could be huge. It could be huge for a few reasons. For one, if the patient isn't able to come in for any reason, then we can still get them either on audio and visual at home. That could be a very impactful visit that drives better health and outcomes with the patient and certainly builds trust. I've noticed when we proactively reach out to patients and see how they're doing and to check in on them, even when they're at, in their house, it generates tremendous trust. The other thing that we're looking into is, I think there's a great opportunity for load balancing. I mean, we haven't gotten there quite yet, as an organization in terms of figuring out the perfect way to load balance. But if if there's one center that has let's say a lot of visits, or even unscheduled visits or walk-in visits, and there's another center that they have capacity to figure out how they can to help to load balance, I think that could be another great opportunity.
So there's several things that I loved about this podcast. I think when there's not a lot of primary care that are going full risk. And so I think ChenMed's leading the charge here as well as several other organizations that we talk to later in the year. But full risk is not about billable codes. You have to really embrace technology, really embrace efficiencies to keep those costs down and proactively outreach and manage patients significantly better than, because of penalties of making sure your patients are not in the ED. So when you look at how to extend that, when you start looking at social determinants, you start looking at rural and population health, you really have to understand those patients and understand if there's transportation issues or if they're non-compliant. And as Dr. Chen said, extending digital healthcare and telehealth into the home to be able to proactively reach is just such better outcomes. And the load balancing is big. As we see models scaling, as we see practices bringing more specialty and things in-house, you can't have the same level of providers and specialists and so forth at every location. In addition, no-show rates, on a daily basis can be 20% at one location and 60% at the other. So you really have to start looking at how can you optimize staff across locations. And from a physician experience standpoint, how do you keep your docs from just running from doing rounds and allowing them to use technology to create better work-life balance for them as well?
Our first roundtable podcast of the year was on August 27th. We had Michael Walser, Justin Ross, and Dr. Sarah Burdick on the show. Let's listen to Dr. Burdick talk healthcare innovation on the medical devices, innovation and training supporting today's digital patient.
It is the first and only technology that has built-in integrated sensors, and we're using AI so that we can look at activity tracking. We can look at social engagement scores. We have tools like fall detection and alerts that would go out to a loved one. So by creating all of this additional value and having it in one device on the ear, which is the most accurate way to track some of these things, we now have a amazingly cool technology that even people who don't have a hearing loss are coming up to us saying, we want one. How do we get one of those?
So if you listen to this roundtable and you listen to what Dr. Burdick was talking about hearing aids, and the direct-to-consumer model, you're now having kind of all these bells and whistles for healthcare that's making things, sexy and cool. In addition, it also creates a lot of operations and training to then support those patients directly that we've never seen in the industry before, which is a completely different operational model. So if you listen to this podcast, you have, Michael talks about how they're using telehealth for concussions with, athletic departments. And Sarah talks about them being, supporting and having AI and tracking to be able to do tech support and features and things like that. Justin talks about how, selling pharmaceuticals and, training employees across the globe. You're having to use video technology and screen sharing and telehealth and things like that. So I think we're going to see a big shift in the direct-to-consumer healthcare technologies from the medical device companies and how they're going to have to use technology to support, national and international to scale it.
So our next section is the year of telehealth adoption. We have 5 different shows in this section. Carrie, can you tell us why you picked these 5 shows?
Yeah, so telehealth has grown 1,900% over the last few years. We've seen a huge increase just from the first of the year, and folks that were talking about it and getting education to implementing. The payers have come on board, both from the commercial payer and the Medicaid side, and then some on the Medicare side. But here, in January, Medicare is going to be reimbursing as home and originating site, which has made telehealth, and I'm not talking site-to-site telehealth, I'm talking about telehealth where the patient can be anywhere, is significant. And so the first one's really about diet and nutrition. They've been doing some amazing stuff at Virtual Health Partners in this space with health coaches. We've seen a huge increase in health coaches this year. So they talk about that journey and flipping from phone to video and what they've seen. Behavioral health. We've done a ton of shows this year on behavioral health and telebehavioral, telemental. This has really allowed stigma, access, rule. We even talk about autism. So that was a great show. And then really around primary care, convenience for patients, the third show, and how physicians in primary care are doing innovative things to, get more business beyond the physical locations, and then connect in specialty, rural access, things like that. The fourth one was really we've seen a big increase in remote monitoring technology this year, and how telehealth is really the last mile of that to really prevent ED and a lot of the anxiety for patients. And then the last one was just a great show at the end of the year, really talking with some surgeons on the ortho side of pre and post surgery, innovative ways that telehealth's being used as caregiver, consult, triage, and then post surgery. So let's get into them.
Yeah, so this first one is the episode Creating Mobile Apps to Drive Virtual Care. This episode was with Jillian Bridgette Cohen and joined by Robert Armstrong, taking place on July 9th.
It's so crazy, Carrie. I don't know if you've seen the same thing, but it used to be so many people just wanted the voice over IP piece, where I was telling you it was like 70% of appointments were voice over IP phone calls right through the app. They still record all of our one-on-one appointments record, so someone can go back and listen to what the nutritionist told them. What I like is only the nutritionist records, not the person. So it's right. Not have to see yourself or hear your own voice. But so it has dramatically increased, where for the first time we're actually in the absolute reverse, where 70% are now video.
So I think what Julian and team have created with recipes and diet, and then following that up with digital health coaches, dietitians that can work from home, has just been amazing. I think the key thing here is they started with phone, and some people were hesitant to get on video when you're talking about a demographic that's, watching, trying to get help with weight and health. A lot of times that can be an obstacle. And as she said, they've now seen it shift, where now 70% is video and 30% phone. I think we've seen a huge shift of folks significantly more comfortable on video, wanting to use it and really create those virtual face-to-face relationships. I think it's been a big year for digital health coaches, and I think it's just the start of what we're going to see as commonplace in the next 12 months.
So Gary Lansonere joined us on November 12th to discuss best practices in scaling a behavioral health organization. Here he describes how telehealth can be adopted for behavioral health organizations.
Up until, discovering your product, hated we literally just wrestled with the technology. We were looking at, we were like, okay, we're just like throw up our hands and we were going to open up a clinic in a rural area that was 3 computer screens, and a social worker / receptionist. Great job. And also somebody who was good with technology, because everything was glitchy. Nothing was working for us. And so it was great. And at all the conferences, they talked about the innovation and everything, but the technology really wasn't all that great. I mean, it can't be, it has to be seamless. It has to be easy to use. The code, I'm sure, is super complicated behind the scenes, but the user interface, it has to be smooth, or else it becomes the topic between the therapist and the client.
Your tech support.
Yeah, and so they're frustrated. They've got their cameras pointing up at their ceiling, and they're, can you see me now? And it becomes all about that and fighting the technology. What you guys have done is make it to where we can use it, because what we need, for instance, in autism, we have a significant issue with autism in Utah, and our rural areas lack trained therapists that because they simply can't make a living in these rural communities. So you've got these children with autism and no specialists available. But you don't need to take the kid to a clinic to log on. What you need is the mother to have, or father, caregiver, to have the ability to click a button and show the behavior to the therapist that this is what they're doing. They're beating their head against the wall. What do I do now? Like, take me through the steps therapeutically of how to intervene. But it has to happen then.
Now. Yeah.
Right. And so up until we discovered your product, I mean, we just couldn't do that. Now, the sky's the limit.
What I really liked about this podcast, and if you haven't listened to the full thing, really go listen to it. What Gary's done in scaling their behavioral health organization, Valley Cares, is remarkable. But this goes to show what we've seen a lot this year is that affecting no-show rates, affecting convenience, access to rural areas, things like he mentions, like autism, really requires simplicity from a telehealth standpoint. A lot of companies have tried to roll out really clunky technology, video conferencing, that's left a bad taste in provider and therapist mouths, really, because it turns them into more of a tech support than being able to do, their medical professionals or providing therapy. And so Gary's organization's done a really great job of, part of scaling is implementing innovative technology and really simplifying it out to from a user experience standpoint. So that's why we selected this one, and it's a really great episode. I encourage you to go listen to the full episode.
Here, Dr. Brian Bluth talk telehealth adoption on primary care, direct care, proactive care, or just good patient care. He was joined by Dr. Ben Barlow on November 5th, 2019 on this episode.
But then to your point about the telehealth, we're also developing that, and it's really helped us engage the patient to come into the clinic and to the facility and directly contact a specialist that they otherwise wouldn't be able to get to see. Our endocrinology group is on the front line engaging patients, and I actually have people traveling an hour further northwest to come to my building so that they can communicate with a specialist in the city through the telehealth method. And so we've got some cardiologists and oncologists and what else? The pulmonologists are involved in it, and orthopedics now. And that really supports the hospital, and it really helps the patient out.
What I really liked about this episode with Dr. Bluth was really the out-of-the-box primary care physicians that are really thinking beyond the four physical walls and how they can scale their practices to connect to other specialty docs, especially in rural access areas where folks are driving hours just to see a specialist in these bigger cities. And Dr. Bluth really highlights great ways in order to reach rural areas to connect other physicians. We're seeing more and more of this and seeing it on primary care, also servicing facilities, acute rehab, long-term care. I think we're going to see a lot more of that for innovative primary care physicians that are really scaling beyond the physical four walls.
So our next two clips come from one episode on September 10th. This episode was entitled The New Remote Monitoring Last Mile, From Alerts to Real-Time Virtual Patient Outcomes. This episode was with Dr. Sharon Stoll and Pete Stevenson. First, we'll hear Dr. Stoll.
If it's for something else, like diabetes, blood sugars are through the roof, or like for my subspecialty, multiple sclerosis, lots of times people are trying to figure out if they have a pseudo relapse or a pseudo flare-up, or they actually have a new relapse. So actually just seeing the patient, conversing with the patient, I don't really even need to do a full exam. If somebody tells me I have a facial droop, if I can actually see their facial droop, if I can hear the slurring of the words, that's all it takes. I could even do part of the cranial nerve testing with the extraocular eye movements on the video telemedicine side.
I think Dr. Stoll really highlighted on remote patient monitoring it gives patients anxiety. It has red flags, things of that nature. That the physical exam, we've heard a lot this year. A lot of physicians pre-2019 were adamant about a physical exam. I think we've seen those walls come down, and it's more and more apparent that through video telehealth, you're able to see things that if the patient was sitting right in front of you. As she explains, from a neurology, from an MS perspective, seeing those indicators through video is immediate action versus driving patients anxiety and driving them to the ED if they can't get an appointment.
And now we'll listen to this clip from Pete Stevenson.
Well, it's a great day for kidney patients and great news for the industry. I have several friends of mine who are applauding that announcement. It's a tremendous motivator also to help drive much needed technology improvements into the renal and nephrology business, which is really left somewhat in the dark ages in terms of the machinery that they use, very heavy. Just yesterday, in fact, I read an article where they were talking about developing an Apple-like dialysis machine, simplified for home use. So there's technology folks out there and entrepreneurs that are going to grab a hold of this and really take a hold of it and make it easier. That last mile is so challenging. Remote monitoring for kidney care includes not only vitals, but also the machinery itself, the blood tests, the labs that are needed prior. All of that can be done in the home. There's technology available today to bring into the home to service those patients. And with platform solutions like what we have, there are opportunities to introduce telehealth for those visits that can be done virtually, see the person, see their environment, get a sense for the challenges that they have in the home, sort of a pre-visit, I can imagine. And then there's in the visit, when it's happening, help in setting up, make sure you're doing it right, getting the information into the machine, if you will, so that it's properly running, and then maintaining that device. So the device becomes then in the home something that they're going to have to, I call it Appleize, but essentially do something with, because it has to be portable, it has to be easy to use, and it has to be, let's say, controlled externally so you can restart it when it's not working or the alarm's going off.
I could really talk for hours about Trump's that came out in summer, about 80% of dialysis patients to be on home dialysis by 2025. This is going to cause and is causing a real shakeup in the dialysis centers and in renal care and nephrology as a whole. I think there's huge operational things that have to be worked out, and we're going to see direct impact of that in home health and in facilities. The only way to really strategize and serve this virtually is moving from these physical locations to a virtual model. That's everything from the case management to the nursing to the nephrology to even doing video support for the Baxter cycling machines and being able to do this instantaneously. So telehealth has to be the last mile to remote patient monitoring.
During the podcast, Telehealth Efficiencies Pre- and Post-Surgery on December 3rd, there were a lot of insights when we talked with Andy Poole, Dr. Sonia Sloan, and Dr. John Noble Jr. Let's start off with Dr. Sloan.
I believe this is where telehealth is going to make a huge difference, specifically in surgical scenarios, because you also need a second opinion. I tell patients every day, no surgery is a small surgery. And so, you may have an older patient specifically with me and joint replacements, or like you said, something big like a spine or whatever, but no surgery is small. So you always want to have a second opinion. I think this is where telehealth will come in tremendously, specifically in surgical fields. Most of the times, probably 8 times out of 10, it's usually the parent and the son or daughter that want to get involved. And so usually it's those are the ones that are calling. They may not have all the specific details. They may not have the x-rays, but it's more of like, what does this entail? What are we expecting post-op? What is the long-term 7-day, 14-day, 1 to 3 months? So they just want to know the ins and outs, basically. And so those are probably most of the calls I get.
I think this clip really talks about what we're seeing, a big change in the industry is that more and more Gen Zs are caregivers to their parents. They're being involved way more in healthcare decisions, and patients do have choices than the old days that you did whatever the doctor said. As she pointed out, this really has caused a lot of additional consultations. As she said, no surgeries are small surgeries. So people want to know their options to surgery or no surgery, what the aftercare, post-surgery, all of those things, and to not fill up the waiting room, to not have the surgeons work more hours, less rotations, less surgical days. You have to start looking at telehealth for some of those pre-consultations that are going to be critical from an operational efficiency standpoint.
Now, let's hear this clip from Dr. John Noble.
I have kind of a niche practice. I do some things that are unusual that a lot of people don't do. So I do get a lot of these patients who come in from 3 or 4 hours away. And so they oftentimes don't know how to initiate it. And we certainly don't want them driving for 8 hours both ways and then come up empty-handed. We want to make sure that it's going to be a high yield if they come in. So nowadays we can get them to send their clinical information. We can get them to send their radiographs. I mean, they can send a disc. Hopefully at some point we'll just be exchanging this electronically from group to group. But for now, we're still having to mail CDs. But we can look at those before they come in. We can look at their x-rays, look at their MRIs, and then have a conversation with the patient and decide, is this something we really need to explore more? And we don't always have to do a physical examination. Now, obviously, if we initiate treatment, we'll need a physical examination at some point. But at least initially, to start the conversation to make this more convenient for the consumer, I think it's just a fabulous way to do that. And that's what we're going to be working more towards.
I think this clip really highlights the patient anxiety of patients. This might be the first time them having this surgery. There's a lot of anxiety that goes along with that, and, also drives healthcare costs that are not necessarily needed in the ED post-surgery. And I think if the surgeon, him or herself, can instantly see and do follow-up appointments post-surgery, what you can see through video doesn't necessarily need a physical exam for these things. And a surgeon, given their expertise in seeing thousands of these, can within a couple of minutes let a patient know that that's normal. It's normal swelling, it's normal heat, temperature, whatever it may be, through video without the need for them to be in the office for a physical exam. And typically those after-hour phone calls when you're not on video is, if you think it is an emergency, go into the emergency room, and we can eliminate a lot of unnecessary costs and a lot of unnecessary kind of comeback on the surgeon's perspective from having a patient go into the ED.
Dr. John Noble goes on to talk about how much a convenience telehealth can bring to physicians and patients.
In the more remote campuses, then we will probably have some type of telehealth presence. So instead of somebody driving 50 miles, particularly in a post-operative case, we can now, it just takes a smartphone to actually video the incision site, and we can do a quick post-op visit. And as you probably know, most of these visits that we come into the first 7 to 14 days, they just really want reassurance. They have normal bruising, normal swelling, and all of these things look normal to us because we see this all the time, but for them it looks horrible. And we can reassure them and say, Ms. Smith, that's just a normal post-operative course. The bruising that you have, the swelling that you have is typical. Some people have more, some people have less. And then, if they call us in 4 weeks, well, that's normal post-operative inflammation. The warmth that you feel and all those sorts of things are normal. So that reassurance really helps us. And it particularly helps from a liability perspective, because the more reassured the patient is, the less likely they're going to get upset with us.
As Dr. Noble points out, he brings up a great point of shortage areas on specialty docs, patients having more options in their healthcare and decision-making, driving hours in a lot of circumstances to go see a specialty doc. And I think the ability to see more patients, have better patient and caregiver convenience through telehealth for that initial consult, sending those files, that's the whole purpose of the EHR and the images associated with that. I think we're going to see more of that. I think we're going to see more of that in facility-based healthcare for specialty, given the cost for transportation, and specialty doctors will have more availability to service these types of facilities. I think specialty has probably been the biggest surge we've seen in 2019, and I think it'll continue in 2020.
And for our last clip, we have Dr. Sonia Sloan talking about the future of telehealth.
Realistically, what I see in the near future, if we're not already there, is the fact that telehealth is going to be utilized as a triage system.
Yeah.
We are going to see most insurance company providers will not allow you to get to, unless you're talking, bone is sticking out, massive heart attack, or, whatever. We're talking the non-really emergent, urgent kind of things that can be seen through a telehealth almost as a triage to say who you should go to, how quickly it should be done, which doc you can or cannot see, and in a timely fashion. That is part of the overhead as well, because I can tell you that I've had patients come in with no, proper triage, and I'm not sure how they get to us, with no x-rays, with no whatever, and now the shoulder doesn't hurt at all, and so they just come in to smile at you. So It was, a wasted visit for both parties, but at the same time, insurances are going to try to cut that out.
I think this last clip is really kind of the icing on the end of this amazing episode, is really the future of telehealth, the triage system. I think we've started to see that from the payer side. We've started to see where copays are higher if you go to in-visit versus telehealth. And the data is there that it is less costly from a visit perspective. And you're going to start to see surgeons that will not have you even come in for that consultation if they haven't done some type of, as she states, triage to understand if you're a good candidate, to review files, as Dr. Noble said, images, things prior to see if you are a good candidate. I think we have to look at the physician experience, the physician's time, as well as the patient experience. And I think it's a really great marriage of what we're going to see in 2020 and beyond. This concludes our 75th episode of the Top Healthcare Podcast for 2019. I want to thank all of our guests of 2019, even those that weren't featured on the show. And we've had an amazing year on Healthcare Podcast. Today's show has been brought to you by One Touch Telehealth and Humans Helping Humans. We look forward to having the most innovative physicians and executives on the podcast. We have some great shows coming up in 2020. As always, remember to subscribe to the show on your favorite podcast player. Get your new show delivered to you every Tuesday. We've already had some great shows lined up for January coming out. And if you want to see the new video portions of the podcast, make sure you subscribe to our YouTube channel as well as Vimeo, or catch us and follow us on LinkedIn. That's all for today's show. Thanks and have a great one.
This podcast has come to a close. To hear more from the Executive Innovation Show podcast, subscribe, submit questions, and share the love. Follow us on social. We're everywhere.